Opto Info, back with another weekly video. It's the Smo versus the pros. We're right into the case. Let's check it out. We just did give it and pivot. We got a white cataract here, and it's fun for a couple of reasons. But first I want to talk about how do you give vision blue. Here you see I'm painting it on underneath some OVD. This is Needle Rosatelli just doing a beautiful injection straight into the aqueous and then exchanging it with HPMC. That works great. Pradeep Mahanta here injecting it under a bubble, and then Brian Kim sort of painting it on under a bubble. And why do we do all this stuff? Why not just inject it and not give it any more thought? Well, you can do that, and I've done it all different ways. Here's me doing it sort of a hybrid of ways, just injecting it into the aqueous with a small bubble there. Come to find out, this patient had some zonular compromise, and that vision blue got around to the posterior segment, and you can see here as I turn the oblique light on and off, there's a what I call a vision blue lack of reflex, and that's no fun. Made the case a bit more difficult. Thankfully, we went find them. So back to this case, if I'm at all concerned about zonular compromise, which we see a lot of, then I just go ahead and inject it under OVD. It makes it a little bit more time consuming, and you have to use a little bit more OVD, but that's no big deal. So going right, continuing with the case, open the capsule up with the cystotome. There was no fluff. Didn't seem like the lens thankfully was not intumescent. So we're moving right along here, switching over. Oh, earthquake. We're in Florida though, we don't have earthquake. So what's going on here? This patient, he was extremely anxious. So, and also had quite a tolerance to the IV analgesia anesthesia that we give. We usually give about 100 mics of fentanyl and 2 of Versed. In this case, he got 4 to 5 times the normal anesthesia. So he went from being super anxious to being knocked out. And so that was him waking up, had no idea where he was. So I was like, oh gosh, this is what we're in for a ride here. So I'm trying to move through things a little more quickly, finishing up the Rexus. Thankfully didn't run out when he started to try to jump off the table and created some posterior pressure there. So finishing up, nice continuous Rexus, going in with a little hydrodissection, and whoop, what do you know, he felt that pressure again. He's trying to jump off the table. We've got like 3 different people jumping on him at this point, telling him, hey, you're in surgery, lay down, don't touch your face. Hands were up. He was taped down every which way, didn't matter. The tape had obviously come off his head. At this point, I can see it's super soft. I skip the phaco, go straight to the IA handpiece, and at any second, he falls right back asleep. I'm talking to him, asking about his job, getting him to talk to me. I don't want him to go back to sleep. Didn't matter. He was just falling asleep in the middle of his sentences. So straight to the IA. I'm ready to pull out any second. Thankfully, it's super soft. You can see it's coming down pretty nicely with just through that small IA port. And I have a decent red reflex when I can get it actually lined up with the coaxial IP. Boom, there you go. What was that? It looked like I jerked, but really it was his head. Thankfully, both hands on the patient's head, was able to pull out. Felt like didn't feel like I had compromised the bag at all. So let's take a look and see. Wolf it down, and everything looks good, thankfully. Sometimes you have those cases where it feels like the patient's just trying to sabotage their own capsule, OVD in the bag. We'll throw a single piece of acrylic in the bag. That's a nice little tip there. Wipe if you have some heme because you nicked the limbal vessels, wipe it before you inject the IOL, because sometimes it'll carry that heme into the bag, and it'll sort of taint the capsule or the lens, and can be a pain to try to get off. So just swipe it. Prevention is preferable to cure. So here, did we go behind the lens and get the OVD? No. I'm just trying to get out of Dodge here without breaking the bag, because this has been 3 or 4 times that he's jumped off the table. He's asleep at this very moment, and it's just a matter. Every time he feels that pressure, he jumps. So we get what we can out of the front part of it. Try to sort of tilt the lens to get some stuff from behind. This is nice, dual wheeled. So I've got one hand with the IA and the other with the BSS, and sort of flush things out of the angle, OVD, and possibly residual pieces of lens that you may not be able to see. Pressure was a little firm for me, so I tried to burp the para, tried to pull the eye down with a weck that obviously didn't work. Was able to do it with a Q-tip. Then I could reach it, burped it a little bit. That feels good. You can see post-operatively he has a thick PCO, but that'll yag out no problem. So that's it for this week. Thank you for watching. Just remember, I'm the schmo. These guys are the pros. I'm trying to drive. We out.